Hello, this is Fernando Gómez Sancha, and this is the first video in this channel that will showcase cases of an atomic enucleation performed with the solid-state thulium YAG pulsed laser from LISA Laser. They have lent us the laser so we can produce this channel. And I'm very interested to explore how this different wavelength to what I'm used to, which is holmium laser or holmium lasers, will affect the way we perform enucleation. I was offered to try this laser when I once was in Bulgaria. And I was very impressed by the quality of hemostasis. So I was curious and I contacted the company. We started talking and they had the kindness to lend me this equipment so I can learn more about an atomic enucleation of the prostate with thulium laser. But in this case, it is a, say, second generation thulium laser that allows for a pulsed mode that will be good for performing, or will facilitate performing enucleation of the prostate. So this is a man with a mid-sized prostate, not so small but not so big, and that's the contour of the sphincter, and you will see how when I fire this laser, the tissue effect is a little bit different. Basically, this laser is going to emit pulses that are a little bit longer than pulses emitted by holmium. Basically, the main difference is that the peak power, the peak energy that the laser emits, is significantly lower with thulium lasers. So the heating of the water in the tip of the fiber is going to be less abrupt, and the subsequent typical explosion that happens with holmium will not happen as much with thulium laser. So thuliums have longer pulses, and the peak power is much lower than what we can have with holmium laser. So if with a holmium laser we can emit pulses that go from 10,000 watts and more, this maximum peak power with this laser will be about 1,300. So that this explosive effect that typically helps dissecting the plane with holmium does not happen with the same magnitude, does not happen as evidently. So this is more an excellent cutting tool and an excellent coagulating tool. And if we have to look for the plane, sometimes we will have to do these mechanical movements, like am I doing now, to make sure that we are following the right plane. But as I said, I see a lot of surgeons who are very happy and who defend their wavelength wholeheartedly. And, I'm very curious to see how important the differences between different wavelengths and laser devices are, and to what extent can we compensate. For example, this laser, as I said, doesn't have the peak power that holmium has, but it has very good cutting properties, very good coagulation properties. So will the surgeon be able to compensate for the differences? And, so I'm going to develop a specific channel with videos of enucleations carried out with this laser, so we can all travel, through this journey of enlightenment and learning where we will see different situations and different cases to see how this laser is allowing us to do endoscopic enucleation of the prostate. And then, I think after a number of cases, we will be able to start understanding, what are the real differences and advantages and disadvantages. What I really believe is that with the new generation lasers, so this means this laser as opposed to the classic thulium, and the pulse modulation holmium lasers as opposed to the classic holmium lasers, and also the inclusion of these thulium fiber lasers, which have a different mechanism of laser production. So I think with these newer lasers, the new generation of these existing lasers and the new thulium fiber laser, probably we have tools that are better than the previous ones. But we still have to learn, what is, let's say, hype, what is company-driven, concepts and evaluation, and what is the truth, or what is the clinical experience that we can get in our hands. So as you can see, I'm replicating the classic en bloc enucleation with early apical release. I have been able to dissect the apex of the prostate away from the capsule in the lower part and on the left side of the patient. And now I am following the usual steps to go up on the right side of the patient and trying to connect anteriorly. So you can see that once I have dissected a little bit of the anterior part on both sides, it's very easy to recognize what remains in the middle at 12 o'clock. Also, the adenoma is dropping, the tip of the adenoma is dropping from the ceiling. So these 12 o'clock fibers verticalize a little bit and we can cut them very nicely. And from this moment forward, I think the technique is quite easy because you have to just go around the adenoma and trying to understand the anatomy. So that was a nodule that I could see, so I could go around it. So the first impressions I got with this laser was, one of them was the hemostasis is very good. Maybe the longer pulse has a lot to do by that. Maybe the tissue is a little bit more affected by the energy effect than what I'm used to using holmium lasers. And maybe the pulses are not opening the plane as efficiently as I would get with one of these pulse modulation, either MOSES or virtual basket lasers. But as you can see, the cutting properties are very much enhanced, I think. It's an excellent cutting. The hemostasis is very impressive, and one of the advantages of the en bloc technique is that you have this line that goes around the prostate that tells you where the plane is, and we have to agree that the shape of the prostate is not a perfect sphere, it's not like a billiard ball, but it's quite spherical. So if we follow this line and we are discriminating if we are in the right depth of the capsule or not, you can discriminate very nicely when you see the plane very beautiful. But if you don't see the plane, you have a lot of indirect data and information to tell you that you are in a good plane. So, for example, the quality of the tissues. You remember that typically the adenoma looks a little bit more yellow and the capsule looks a little bit more white. Here, there is some alteration of the colors as I am used to see them. But still, I think the fact that we're going around the adenoma following this line, which was performed at the right depth, and the fact that we are analyzing feedback from the screen all the time to check if there is adenomatous tissue left or not, I think with experience one can do a very nice anatomical enucleation even when the plane is not perfectly patent or visible. So here you probably will agree with me that the tissue is a little bit coagulated or fused, or there's some effect that is not allowing us to see the beautiful glistening surface of the capsule. But this also happens with Moses and virtual basket. As I said, we are always judging if the depth is correct. That is the sign that we look for. Circular fibers with vertical fibers below. This is the place where we enter the bladder. So that's an opening now at 12 o'clock. And we have to cut the bladder neck coming down. One interesting aspect that I find with this laser is that when you use holmium, the explosive effect damages a little bit the mucosa, and there's a tendency for bleeding in the mucosal edge, and definitely you have to do some hemostasis and coagulate the edge of the mucosa when you finish the procedure before you start morselation. But here you can see that these longer pulses are more hemostatic, and when we open the bladder neck, there doesn't seem to be much bleeding coming from the mucosa. So maybe these longer pulses with a lower instantaneous energy generate a little bit less explosive effect and a little bit more coagulating effect. That's why the tissue changes like that. But as you can see, it allows us to progress very fast, and it provides excellent hemostasis. So these are desirable qualities in a laser for enucleation: the ability to cut and coagulate. And there we are progressing. Cutting the mucosa all around, just following the same steps of the Bloc technique with early apical release that I usually do and recommend. I really think it's an approach that is universal. You can do this procedure using the same technique with different sources of energy. And as you can see, it is very fast. It allows you to see very well. The irrigation is excellent. So it's very exciting to be able to try a new tool. One possibility with this laser that cuts so well, there might be a little bit more difficulty finding the right plane for people who are beginning with holmium. On the other hand, the excellent hemostasis helps beginners in the sense that the visibility throughout the procedure is quite good, so you can decide, where to go, where to correct, where to cut. So it's quite exciting. I was very impressed with this laser. The quality of hemostasis is amazing. We feel that sometimes it's a little drawback to not be able to have this dissecting effect, but so it was interesting. We did a session with many cases. I have recorded a lot, so I will try to post more videos. And the reaction of my nurses was total enthusiasm because of the quality of the hemostasis. So wonderful, really. But as we progressed with more and more cases, they had their doubts. So I think it's a difficult call for all of us to choose our tool. I mean, what would be our favorite tool? And Well, it's very impressive also to see, and I hope to post some video, how easily this laser breaks the stones and pulverizes stones. So when you have a combined case with bladder stones and BPH, it's not going to be a problem anymore to work with thulium, because they have managed to provide very, very nice and very efficient lithotrips. Here, for example, I am trying to correct and investigating a little bit to see if this plane, if we left a little bit of tissue there. So I don't mind digging a little to find out. And I probably was not convinced that digging deeper was necessary. So this is the evolution. Recently we have had interesting discussions about laser physics on Twitter, and I have to say that laser physics are very cryptic to me. I remember I bought a book on laser physics, and I could read only the foreword, because the first page already contained very complex formulas, and then the whole book was like that, formulas and formulas and formulas. So for me, who I'm not a very good mathematician, or my knowledge in physics is limited, it was very difficult to comprehend. But of course, we have the experience in the operating room. Also, you know, these fibers are degraded very fast. They degrade very fast, and probably the physical properties of the laser coming out of the fiber change very fast when the fiber degrades. But we keep working, and we keep using this energy. We cannot stop every 2 minutes to cut the fiber and continue. So we have to adapt. And then overall, I think there is a clinical impression. I always say, because people let me try a laser and they say, "What do you think?" And I say, "I don't know. I have to do, hundreds of cases to start grasping the reality. What's the final balance, let's say, or the final opinion, because it's not easy. Often some prostates are much more easy to operate. The planes are much more evident. Tissue quality is very good, and you might think, wow, the laser is so good, but it was actually the case that gave you a lot of help, because the patient was sympathetic with you, had a nice sympathetic prostate, as I usually say. But here we are. This is the finalizing moments, as I do with the holmium when I'm negotiating a plane that is turning. I keep my fiber very close to the adenoma, so most of the energy goes to the side of the adenoma and not deepening in the capsule. So the same principles apply. And here we're just finalizing the enucleation. It was not a very large gland, but it is now 18 minutes, 25 seconds, so probably we will finish the case in about 20 minutes. At least the enucleation part. So it's a pretty good and pretty standard nowadays for prostates such as this. And I'm very happy that the tools are constantly improving, and companies are investing a lot of money to improve our experience as surgeons. I think we are going to see a major adoption of anatomic enucleation worldwide. We are seeing it. I get requests from people who want to be trained and who want to learn, who want to visit almost every day. Someone is writing us and saying, "We want to visit you, we want to learn." So I can tell you the interest in HoLEP and endoscopic enucleation is peaking right now, as it had to be, because the results of this technique are amazing. The postoperative recovery is fast. You can do it in high-risk patients, and that's the final result. You can see the mucosa is very nicely preserved. That is the fossa again. Pretty regular and nice. And this is the trimming phase, the final phase. Here it looks as if I left a little bit of tissue, but we can Again, with the anatomical information of the shape of the capsule and the cavity, you can tell, we are not leaving major bumps. Here, what I was doing, I think, is introducing an ultrasound in the rectum. And that's the image we got on the transverse and longitudinal view. So it was a very anatomical job. And that was very satisfactory because the ultrasound doesn't lie to you. If you leave a rim of 2 or 3 millimeters of tissue left, it will show very patently in the transrectal ultrasound. Here I am changing the laser cystoscope for the nephroscope. I always say that this operation needs a very highly trained team that can help you to do fast changes, and you can see that the quality of the hemostasis is evidently very, very good. In the initial moments, the Morselator has to be primed. The tubes have some air, so it's often there is an initial moment where Morselation might not work. Of course, you can try to prime the system outside of the patient, like using a capsule on water. You can try to see what's going on, but there is some suction problem for the moment. It looks... Let's see. The first 5 minutes usually can be like this often, and then for some reason things start working better. Of course, hemostasis is important because it also adds safety to the procedure. If you can do your morselation with such good view, morselation is much safer, of course. So we have now better lasers, better morselators, and of course the Bloc technique that allows you to progress very, very nicely, very fast, and as well as protecting the sphincter so that temporary incontinence is no longer a concern. We don't tell the patients that we have to expect a high possibility of incontinence. We don't do pelvic exercises. We don't do anything like that. And this first evaluation of this laser is very, very intriguing, very satisfactory. I will keep posting videos. I hope you will comment down there and subscribe to the channel if you want to keep abreast of advancements in laser for BPH.